Hello and welcome to the Rural Doctors Programme. I'm Jerry Gannon. As always, thanks for your company. In this programme, we take a look at some of the issues surrounding aged care. But before we begin, here's Rural Health West's Manager for Workforce Development, Kelly Porter, with news on the new telehealth service.
Telehealth has been around in Australia in a number of guises for quite a few years. The recent introduction of the Medicare item numbers and incentives for telehealth consultations has seen an increase in the clinical care provision in the primary care setting of telehealth. Rural Health West has set up the Western Australian General Practice Telehealth Advisory Group. This is done in conjunction with the WA faculty of the Royal Australian College of General Practitioners. The group provides a forum for medical practitioners to discuss their telehealth requirements, to address barriers to telehealth, to talk about their successes, and also it provides an advocacy service for raising issues at a national level. In addition to the WA GP tag, as we call the General Practice Telehealth Advisory Group, we also have a series of telehealth workshops that we provide. These have been set up for those practitioners who really are not sure where to start in providing telehealth services. So we provide basic information on how to get started. We work with practice managers to talk about processes that can be implemented into their practices. We provide impartial advice about technology requirements and how to set up a clinic and how to actually conduct a telehealth consultation. Rural Health West has also been funded to provide the Advance WA Telehealth project. This funding has come through the Federal Government Department of Health and Ageing. And with this funding, Rural Health West will be employing 2 telehealth support officers to provide telehealth support to your practices.
A few GPs have already taken on telehealth in their practices, but we're here really from those who have no set up at all, so we can help with initial software and technical issues, also with workflow design and practice setup, right through to the actual service provision and linking them with other service providers in the metro area or specialists. We can help with the Medicare benefit schedules items and financial incentives through the practice incentive programs. And so we're here with resources and hands-on help. And if need be, we would travel out to services in the country or the outer metropolitan area to help start up your telehealth service.
The implementation of telehealth is a really exciting project. It's going to add real value, particularly to rural Western Australians who have difficulty accessing medical care. It will save them travelling distance, it will save time, and particularly for patients who are in pain and having trouble reaching their specialist, this is an incredible service. So if you're a general practitioner or a specialist, practice manager or member of practice staff who would like to get started in telehealth, just give us a call at Rural Health West and we can put you in touch with our telehealth support officers.
Thanks, Kelly. Now let's get into the programme. The circumstances around providing end-of-life care can sometimes be a bit tricky. Having a clear course of action that's been discussed in advance can be really helpful. We spoke to Dr. Audrey Koay about Advanced Health Directives.
Audrey, welcome to the program.
Thank you.
Advanced Health Directives seem like a really valuable thing to have in place at the end of life, but I guess like anything, they have to be put in place well, or they could be more problems than they solve.
Absolutely.
Can you just talk us through what you consider to be the main aspects that need to be in place for a good Advanced Health Directive?
Absolutely. So the legislation which was introduced in 2010 introduced 2 ideas. One was an Advance Health Directive and the other is the enduring power of guardianship. And it basically borrows from the idea that adults may wish to make informed or decisions about their end-of-life care. And for many years we've been putting together living wills. The actual status of those in terms of the law has never been certain, or there's always been some question. So the legislation sought to ensure that there was clarity as to the legal standing of Advanced Health Directives. What we found, having put that legislation in place, was that you need far more than just that. And I think the most important aspect from what I've seen has been the conversations that actually underpin the Advanced Health Directives or the living wills. And I would even go so far as to say that the conversation is probably more important than a piece of paper. The piece of paper just, could potentially give you peace of mind that what you want or what you say you want will be respected. But if people know what you want, theoretically you shouldn't need that piece of paper. So I say talk to patients. Patients should talk to their families. I think as clinicians we need to support patients to understand where their disease will be taking them, what the concerns may be, what the future care options may be, and I think patients also have a responsibility to tell us and their families and next of kin and etc. what they expect, or perhaps what's easier for patients, what they don't want to happen to them.
Having a formal legislated basis, though, surely can be helpful for
Absolutely.
GPs and other people as the base for a process.
That's
for
right.
those conversations to occur.
That's
so
right.
how would you recommend that GPs and other people broach the subject of a living will or an Advance Health Directive?
One of the things we've found is that often patients will bring this up themselves, and they have leading questions that they may ask, like, what if this doesn't work? Where do we go next? And often they will drop hints that they do want to stop a particular treatment. So I think it's our responsibility then to actually pick up on those hints. Some of the things that make it difficult are things like time, but in a busy GP clinic or in a hospital. Sometimes the environment. If you don't have privacy, if you don't have the family about, you may not feel like having those conversations. And so I think it's putting into place structures that allow you to do that.
What kind of things do you mean?
You may want to invite the patient to come back for a longer visit. You may want to invite them to bring their family with them, because often the family will ask questions that the patient may not be thinking about or may be concerned about but may not want to raise. And it's also useful to have some of these upfront conversations about where the patient's going with the family present, with a view to anticipating grief and bereavement subsequently. One of the other things that we've also started putting together within here has been like a toolkit, if you like, about things, hints that patients may drop, but also things in the patient's disease process that may make you think, oh, this patient may be someone I want to talk to about this. And it may just be questions you ask yourself like, would I be surprised if this patient's dead in 12 months? Or as we continue to add more treatments, or as patients come into hospitals, frequent hospitalizations are often another trigger that make you think, where is this patient going?
Can you just talk us through what the legal basis for them is? Do they expire?
They don't. And therein is a risk for the patients and for us. So we all know, I mean, there are people who make a will and who go back and revisit it. I don't actually have much in my account, so there's no reason to do that. But similarly, with an Advance Health Directive, it's easy to write one, put it in the drawer and forget about it. Often what happens is that as we get older, or as your disease progresses and it happens over a chronic process, you adapt. And things which you think may once have been unacceptable suddenly don't seem quite so bad. So you may well change your mind as to what you think constitutes acceptable quality of life. Other things that happen are treatments change. So where you might once have said no to, say, resuscitation, or you might well now want to say yes if you knew what else was around. So one of the things that the Advance Health Directives has in it is like safety catch, if you like. So if someone wrote an Advance Health Directive, say 10 years ago, it's still a valid document because they haven't revoked it. But if the disease treatment options have changed, if the patient didn't know of these at the time that they wrote the document, and if a reasonable person would have changed their mind, then you could argue that it's inoperable. And so you may well want to, despite that Advance Health Directive, initiate a conversation about treatment.
So the process then, particularly towards end of life, should be an ongoing one. It's not like something we go through once, they write it down and everyone signs off on
not.
it. It's something that through that process we need to revisit when there's a change in their circumstance, their diagnosis.
And even if there is no change, you can just decide that I've changed my mind.
So what kind of things should they ideally cover?
It all depends on what's important to the patient.
Sure.
I actually think an Advance Health Directive is very difficult to write if you've got a stable condition or we find a lot of people write them out of fear for example, being in a persistent vegetative state when they've not actually got anything terribly wrong with them right now. I think the Advance Health Directive has most value when you've got a condition with a defined prognosis, you know what might happen to you, and you know what situation you don't want to be in. So the form actually allows you to specify the situations and then the treatments you consent or don't consent to. So I actually find the Advance Health Directives a useful tool, and it is supported by legislation which provides clarity. But perhaps what's more useful for the rest of the population is actually the enduring power of guardianship. That's a concept in which you can appoint someone you trust and who knows you well to actually make decisions on your behalf. Now, the issue with an Advance Health Directive is you can only imagine X number of scenarios, and chances are those won't actually happen to you. Whereas in an enduring power of guardianship, you can advise your guardian as to what you may or may not wish to avoid, treatments that you consent or don't consent to, and then they can make those decisions on your behalf.
Are there circumstances where standard medical practice would contradict an Advance Health Directive? And if so, how do we get around that?
So you can't use an Advance Health Directive to request treatment which isn't clinically indicated.
Sure.
All right, so that's the first. I think the more common scenario is where the clinician looks at your Advance Health Directive and thinks, that doesn't seem very sensible. I think if you then had the opportunity to speak to the patient, you would, or to their enduring guardian, you'd certainly take that up. You'd probably want to understand the circumstances in which the Advance Health Directive was written. For example, one of the things that will come up is, what did the patient actually understand? Did they have capacity to make this decision when they wrote that? And often what happens after a conversation with the family, if that doesn't resolve it, you may actually want to refer to the State Administrative Tribunal. The difficulty for clinicians is that the Advance Health Directive has a legal standing. There have been changes to the criminal code to protect clinicians if the patient does die or suffers an adverse outcome because they were acting in accordance with an Advance Health Directive.
Sure.
So the converse of that is we expect you to respect it.
A lot of those issues, surely, though, will disappear if people are mindful of
That's
whether an
right.
Advance Health Directive is in
Absolutely.
place, and as disease progresses, constantly reviewing what should be done.
And I think that's where the conversation with the patient before they write this is very important. It's not the piece of paper at all, it's the conversation.
And our thanks to Dr. Koay. Heather Freegard is the Programme Coordinator of the WA Dementia Training Study Centre, where they educate GPs on how to identify, manage and treat patients with dementia. We spoke to her about the current thinking around the management and assessment of this condition.
The challenges of assessing to determine a diagnosis of dementia are huge, particularly the limited timeframes that GPs have in their consulting rooms. The ability to develop a relationship of trust is really challenged under those areas. Cognitive decline can be caused by a whole heap of other things. And so the first thing that a GP can do is to eliminate all those other forms of cognitive decline, all the other causes. So taking the appropriate blood tests and whatever is really useful, because a true diagnosis of dementia is still only the elimination of all other causes of cognitive decline. The decline over time is also worth noting, so that traditionally the diagnosis takes about 6 months. So you do a range of tests, and then in 6 months' time you come back and see if there's been any change. And that change is indicative of something progressive happening. That can be a challenge for the families and for doctors who need answers.
Well, we had to go through the diagnostic process twice. The first time I wasn't involved. Mom was diagnosed officially in August 2006 with Alzheimer's disease. A few months later, she came to live with me, and it was at that moment when I realized just how much she had changed. And she was arrested by the police for inappropriate behavior, which then triggered a whole series of events, including the diagnostic process again, because her behavior wasn't characteristic of Alzheimer's disease. So one of the things I would be saying to health professionals is that you have to scratch the surface. Putting a diagnosis of Alzheimer's disease simply because it's the most prevalent disease that causes dementia is not sufficient. In our case, the misdiagnosis resulted once going through the diagnostic process again, which is quite a horrendous experience, but also it resulted in dementia-specific services denied to us because the diagnosis was in question. So after going through it again, this time I was driving the process, not my father. We had a diagnosis of frontotemporal dementia, which needed a completely different management strategy to Alzheimer's disease.
I think one of the important aspects is to listen and take note of the person's spouse or family or whatever. And very often it is them that actually make the initial contact with the doctor to say, look, I'm worried about my spouse, my mother, my uncle, whatever. There's something going wrong. But he won't come to the doctor. He doesn't see there's anything wrong. And so it is really important that the doctor listens to that because more often than not, they're right. And it's the changes in behaviour over time. So that someone has always been a great cook, and now they've started putting salt instead of sugar in the recipe. Or they've always played tennis and been a good tennis player, but now they don't know when to move from side to side when they're serving. They're things that initially family can say, oh, this is just getting old or whatever, but it's the accumulation of these small behaviours. It has been said the best way to make a diagnosis is to live with the person for 2 weeks because it's the accumulation of the strange and odd and annoying and frustrating things that they do and don't do that can actually alert someone.
What you see is not always all there is, and many people with dementia behave differently when they're in public. There is a level of awareness where they are on the best behavior, so to speak, while carers at home see a different aspect to what the condition is, guess the impact of the condition on the person with dementia, yes, different. So in many cases, my experience was that I had to be mom's support, but also be as an observer to the side, an observer almost from a clinical point of view, so I could describe to the health professionals what was happening so they can make a diagnosis, because simply from the interaction they had in their office, for a few minutes or half an hour or whatever, it wasn't sufficient. The diagnosis very much relies on the information that the carer can provide.
Confidentiality is a huge issue. And negotiating it is a very fine line. You do have to involve third parties at some point. Very often it is the spouse or the daughter who brings the person to the doctor and say, will you give this person a checkup? They may be in the room in that process. You may invite them with the person's permission to stay. And very often one of the guises can be, because you're a little bit hard of hearing, do you mind if your spouse stays, to make sure you understand? You have to use those little tricks.
The traditional definition of the patient, which looks only at the person with the illness, needs to be expanded when in the dementia world. When you enter this world, it has different rules. What applies in mainstream society no longer works in this world. And the definition of patient needs to include the person with dementia and also their primary care. The condition is absolutely devastating on the person with dementia. And you have to watch this. But it also can be devastating on the physical and mental well-being of the carer. I can't describe the level of stress that you are under. And I don't think that anyone can describe it to you when you start the journey. And that is probably just as well, because you might think that, my God, there's no way in the world I can do this and survive the loss and the grief and the exhaustion. But you do it. Whenever you get to the point when there's nothing left, there's still something left to keep going the next day. So they have to look at both, because without the primary carer, whose whole purpose now is to care for their loved one, something happens to that person, the person with dementia is left on their own. So you have to look at both and look at them as a unit that needs support and caring.
People want to remain in their own home. For the families of people with dementia, that can be a challenge. And the desire to keep someone at home needs to be tempered with a whole range of considerations. The person with dementia may not settle easily in the home. They may no longer remember it as their home. They may not remember or identify their spouse as their spouse. They may get lost, and if you're on a large rural property, getting lost can actually be life-threatening. So we need to consider the situation of the person with dementia. We also need to consider the situation of the primary caregiver, often a spouse who is also elderly. So they will be having their own health conditions in addition to managing the person. And if the person is, for example, not sleeping, wandering up at night, the carer exhaustion becomes an issue. And some people are not designed to be carers. They're perfectly good spouses and wives and daughters and things, but caring is not something that is in their nature, particularly in the advancing stages. Also, the physical location, how far they are from services, how far they are from family and friends, from crisis help. What's available in the district? It's actually a very complex equation to determine whether a person can or cannot stay at home, and it is generally the spouse stress or the primary carer stress that determines whether a person can or cannot stay at home.
It's very hard to have your loved one in a nursing home, because no matter how well they are cared for, they will never be cared for as well as you can care for them at home. And in our case, the decision to put mum in a nursing home was no longer a decision I made myself. It was a decision that was imposed on me because we couldn't get any community care assistance at home, and because of her at-risk behavior and the involvement of the police, I was forced to place her in full-time care. She had to live in a psychiatric ward for up to a year before we found a place in a nursing home. And the psychiatric ward is absolutely not a place for a person with dementia. I went from relief just because I knew she was going to be safe to being absolutely horrified by the time we left that place. It's just the way it is. And there were other people in the ward and other psychiatric wards that have dementia, and they have to be there because they need full-time care, and they can't be cared for at home any longer, and there's only so many care facilities that can provide care for people with difficult behaviors. So it was really difficult to see Mum both in the psychiatric ward and in the care facility, because there was only one thing she wanted: to be at home. But I couldn't provide for her at home.
An important role of the GP is to encourage carers to take care of themselves before it becomes a crisis. So often carers don't like to accept help because they see that as a failure or for whatever reason. And so it's often when there's a crisis, the carer gets sick or there's a behaviour problem that can't be coped with. And then dealing with a crisis, you have to deal with what you've got. You don't have time to plan and those sorts of things.
Sometimes the carers take out their frustrations on their loved ones. The stress is so great, and they can no longer disassociate the behavior from the person, and they forget that the behavior is caused by the condition, and it's not intentional. So they take it out on them. Luckily, I only did that once when I just screamed. And I didn't. It was just very loud scream because I was at my wit's end, and I needed Mum to just stop talking. And it was the only way I could think of doing it at the time. It was horrendous, and I feel guilty to this day. But after that, I learned a number of coping strategies, and I also learned that my behavior was making her behavior worse. So I had to adapt what I was doing. This is a key conversation that the GP must have with the carer to ensure that the carer, understands the behaviors of concern are because of the disease, not because of the person.
And another important role for the GP is to actually work in the community to strengthen the resources that are available, using their influence in a community to encourage volunteer services, whatever is required to create that sense of community. A person with dementia can be maintained at home for longer and have a better quality of life if they're not isolated, if the carer has a great support group and the person with dementia has opportunity for meaningful activity.
Carers are under a great deal of stress, so they have limited ability to absorb information. They might not always realize what's important to share with a medical professional. They have a limited ability to cope with new situations, and a great deal about dementia is the uncertainty level. A lot of people want to know when, is something going to happen? When are they going to get worse? How long have I got until, something that they, dread will happen? And nobody can tell them that. It's just impossible to predict. The journey, both for the person with dementia and the carer is It's very personal, and not people are impacted the same way. Medical professionals, they have to think differently. When they look at, at helping with the strategy, they need to take the condition into account, and also the carer's ability to implement that strategy. For example, mom fell out of bed while she was in the nursing home and she broke her wrist. That was about 2 years ago. Now, besides the fact that it took staff more than 2 hours to find out, because she had lost all communication skills, so could no longer verbalize that she was in pain. And then it took, I don't know how many more hours to get to the hospital, and all she got was Panadol for pain, because that's all they can give, in the nursing home. She had to attend the fracture clinic 4 times, because it took staff there that long to come up with a cast that not only addressed her fracture, but also her condition. She actually pulled off her wrist 3 casts, and in the process did significantly more damage to her wrist. And then I got put in the difficult situation of having to decide whether she was going to have surgery to repair the wrist, or she was going to have a deformed wrist after that. You have to think differently. The standard approaches no longer work.
The other really important role for the GP is to connect the person with services, particularly making sure that they know about Alzheimer's Australia, for support for family members and the people with dementia. They have a 24-hour crisis hotline. They have a library which is free. They have people, they have training, there's regional support groups, and they're the really important things that you can encourage a person to do.
If the health professionals can establish a relationship based on trust, particularly with the carer, because they are the ones who will hopefully remain lucid through the whole experience, then I think it will benefit both parties. The carers will feel more comfortable discussing issues with the health professionals, and the health professionals then know they are having a positive impact and really assisting the family.
And thanks to Heather and her team. Next up, Psychogeriatrician Dr. Steve Fenner and his team at RPH speak with us about some of the main issues to be aware of when dealing with psychogeriatric patients in the rural primary care setting.
Steve, it feels like there's been a bit of a push for better diagnosis and treatment of a lot of mental illness in elderly patients. I feel like that's happened. Do you feel like we've achieved anything, or do you still feel like mental illness in the elderly is underdiagnosed and undertreated?
That's a complex question, and it comes, I think you're right, there's a push to make a diagnosis, and to make a diagnosis earlier with milder symptoms in older patients. It comes from 2 directions. There's the lobby for the early identification and initiation of treatment in dementia, particularly Alzheimer's disease. And there's also something that we've been on about for many years, the detection of depression, and then you could say within a healthcare environment, the detection of delirium as well. We feel that depression has been often missed, or we know it has from surveys, by general physicians, GPs, surgeons in general hospitals, missing a diagnosis of depression, and then when they do identify it, undertreating it. And we've been giving this message probably for several decades now, and it's been certainly heard. The problem that I see from a perspective of a general hospital is we get now an overdiagnosis of depression, people who are actually just sick, or just maybe slightly delirious or demoralised or something. The idea of depression is so widely promoted and understood that they'll often be diagnosed as depressed, put on an antidepressant. I mean, in fact, that wasn't the main problem. And while that's happening, cases of real depression are still being missed. So it's really complicated things, in fact. But the increased awareness of mental health issues in the elderly has been a useful thing. We're getting now people referred to psychiatry at an earlier stage when we can assess, try to deal with the complexity and see what elements of therapy need to be introduced.
Essentially, you flagged that there's still underdiagnosis, but overdiagnosis of depression. Where do we go with it? As a GP, what would we be looking for to try and tease out what you feel is depression as opposed to not?
One of the problems here is depression is a rubbery concept outside of good psychiatric practice sometimes. We actually have quite a firm idea of what we think is a depressive syndrome. We have several classification systems like the ICD-10 and the DSM-4, the American system, and there are several others actually which are less known. And they differ a little, but there's a reasonable consensus about what we regard as a depressive illness. But around that, there's a large halo of people with some depressive symptoms who are basically unhappy, not well adjusted, not motivated, that we don't think would qualify for the label of a depressive illness, and probably don't respond that well to antidepressant medications, but nevertheless have unmet needs. In the elderly, we think that the prevalence of core depression, the illness kind, where the response to biological treatments like medications is actually very good. The prevalence of that type of depression is no greater in an elderly person than it is in a young person. And various measures depending on how closely you define it, but somewhere around sort of 1 or 2% in the population would be, some estimates say 4%, would be about right, regardless of age. Some studies actually show a decreasing prevalence of that kind of depression with age. But the other kind of depression that outnumbers that probably 10 to 1, people who are unhappy, poorly adjusted, not enjoying their lives, not motivated, demoralised, that is much higher in older people. And it correlates with things that are not really surprising. Things like widowhood, institutionalisation, all the various losses that go along with ageing, including physical disabilities, chronic pain, physical illness, strokes, things like this, and social isolation, the erosion of the social network. So people who are lonely, basically. Those things correlate with depressive symptoms, but not particularly with a strong depressive syndrome. And the implication of that is that if you identify that type of depression, it's unlikely to respond to an antidepressant. Nowadays, prescribing antidepressants is a relatively easy thing to do. The chance of side effects is much less than it used to be with tricyclic antidepressants. But really, that subsyndromal depression is much more likely to respond to a thoughtful, holistic approach to the patient, thinking about their social network. Would they respond, would they enjoy participating in structured social activities such as a day centre or some club or interest group or a church? Would they benefit from physical activity through a physiotherapy program or some exercise group? Most people who are not depressed will still enjoy seeing their grandchildren and various things like this. But if the person's really numb to those type of pleasures, not enjoying them, it probably indicates a core depressive syndrome which would likely respond to an antidepressant. Once we've done that, we would also do the other things I'm talking about, the social and psychological interventions that might also help. If someone doesn't have those core features, if they are merely unmotivated and unhappy, and you can see lots of targets in their context that could be changed, it's better to do that first before jumping to an antidepressant. I said that the SSRIs particularly are relatively benign and easy to prescribe, and there are a few side effects. But in fact, with elderly people, hyponatremia is relatively common when people are just put on an antidepressant. And you have to check the sodium afterwards, but sometimes that can make people quite unwell or chronically unwell, and it can actually mimic depression, so it becomes confusing.
Well, that leads to another issue, which is just the number of medications that some elderly people are on.
Yes.
And trying to tease out side effect from circumstance, from core depressive illness or any other mental illness. Have you got any thoughts on that for GPs about how to manage that?
Well, I'm sure they're all aware of the general principles that the greater the number of medications, even if the mechanism of interactions is not clear, that it's simply the number or the burden of medications people are on is a poor prognostic indicator. And but it's particularly anticholinergic agents, and I mentioned tiotropium because that's one that is often not picked up. I've spoken to respiratory physicians who hadn't sort of thought it through enough to see that tiotropium is strongly anticholinergic and could be bad for the brain of a vulnerable person. The old tricyclics, some people are still on them and they have tolerated them well for decades, but because of this white-anting process with age and neurodegeneration, it gets to the point where they can no longer tolerate that medication and it will make them delirious or appear to be depressed. Sedatives, of course, people will end up on sedatives for sleep or for anxiety on benzodiazepines, but sometimes that combines with analgesics to produce just a general sedating effect. And once again, if your brain is compromised by chronic processes in the background and it's already struggling to make sense of the world, if you like, if you're struggling to put everything together, all the sensory cues we use to make a model of the world, if your brain is struggling to do that and you add in analgesics and sedatives, it reduces the brain's capacity and you fall below the threshold and you start to become confused. It can look like dementia, in fact. So, yes, it's a matter of reducing number of medications in total, where possible, looking out for anticholinergic activity, looking out for particularly for sedatives and analgesics and trying to get the balance right and minimise them as far as possible. Really, benzodiazepines in the elderly are generally bad news. You know, it's better to use other things if possible.
And there are some other options?
Well, there are some. It depends what you're using the benzodiazepine for. If it's for anxiety, often that is an indication for an antidepressant. So it's probably safer to try an SSRI or another antidepressant in someone who's chronically anxious.
Which can be as effective for anxiety as
well,
it can be
in the
for
longer
depression.
term, yes, it does seem to, it can remove the anxiety rather than just treating it symptomatically. Patients often resist that because they get an immediate benefit, immediate sort of sense of relief from taking a benzodiazepine. So often it has to be a gradual transition with a lot of explanation to convince people that the antidepressant would be a better long-term solution. We have managed to greatly reduce the prescription of benzodiazepines to older patients within the general hospital by making the junior staff aware of this. Delirium's a big issue in the hospital setting. That's usually, it's highly prevalent. It's probably, for an elderly cohort, you'd expect somewhere around 50% of people who are acutely unwell will become delirious, if only briefly, during their hospital admission. So it's, in a big hospital, it's highly prevalent, but it's usually missed. The people doing the job of treating the infection or the trauma don't notice, or certainly don't record in the notes, the diagnosis of delirium, and so they deal with the behaviour on a day-to-day basis. So we're trying to encourage them to be alert for the signs of delirium, to recognise it, diagnose it. That helps with coding and therefore in the future for funding, but also it helps us to actually institute the kind of complex treatment that we do for delirium. There's no one solution, but just in optimising the person's physical health and their immediate environment. Delirium comes up and is referred to us as a problem usually when it's associated with disruptive behaviour. So someone who's unwell for some reason, or maybe someone in a rural setting who's neglected themselves, someone who's rather socially isolated, maybe alcohol dependent or recently withdrawn from alcohol, who becomes acutely unwell, and there are behavioural disturbances, and that's when delirium is usually presented to us. So a behavioural disturbance may be the presenting problem, but it may be in fact the undiagnosed sepsis or hypoxemia, cerebral hypoxemia from cardiac failure or something like that. This is the real problem that needs to be treated, and once you fix that, the behavioural problems, emotional dysregulation, etc., fix themselves secondarily. So for that reason alone, delirium is important to recognise. The other thing about delirium is that people can be, and it's possibly more common than what I just mentioned, behavioural disturbances, people can be quiet and behaving themselves in hospital or at home, but rather drowsy. And they can pull themselves together for a quick interview, exchange a few sentences, they seem reasonably oriented, etc. But as soon as the conversation starts to become predictable, they'll drift off, their attention drifts. And it's that lack of attention that's the hallmark of delirium. So I'm describing their somnolent delirium, where people are not particularly disruptive, but a bit sleepy, a bit inattentive, and when there's no pressure on them, they're actually quite disoriented. They're in a sort of dreamlike state much of the time. And sometimes that is diagnosed as depression. And now we get patients in a hospital setting referred to us with depression, query depression, what treatment should be instigated. We're telling the referrer, actually, we don't think this is depression. We think that your patient is still delirious after their surgery 2 weeks ago. And we suggest you look at their electrolytes and their hydration and their environment, put them in a less stimulating environment, and etc. All the general things we do for delirium.
If a GP suspected delirium, are there things that they can do as a first line before, especially in a rural and remote setting, where they might not have immediate access for psychological referral?
Yeah. The key thing is the primary thing, to look for the possible factors that are causing the delirium. And I was about to say the cause, but sometimes it's a mistake to think there is a single cause. Sometimes you find something like undiagnosed sepsis, etc. But in someone whose brain has already been white-anted over some years with neurodegeneration, small vessel white matter disease, or the processes of Alzheimer's disease, it doesn't take very much to make them delirious. And so it might just be a combination of sedative medications, a bit of dehydration, a bit of sleep deprivation, and a mild urinary tract infection, all combined, or a bit of over-medication or anticholinergic medications, such as people who are on medication like tiotropium, we find nowadays. Tiotropium bronchodilator is strongly anticholinergic, and it's often not appreciated by the prescriber that combined with some other cause might make someone delirious. Basically, I think our main message is that medications are seldom a good answer in the elderly. It's better to do other things, psychosocial interventions, thoughtfully done with the help of a psychologist or a social worker or a physiotherapist. These people can often come up with strategies that help to motivate someone, and the patient themselves feels that they're participating in their own care.
What kind of activities, again, from a rural and remote GP perspective?
These services are sometimes hard to find in a remote rural context. Well, I think social activities. I mean, we get some people choose to live in remote rural areas because they're reclusive. And then it's a mistake to force them into a social context. But for most people, they actually enjoy group activities. And there will be things on. Sometimes the local hack services are running groups through day centres, etc. It could be furniture restoration or just social groups or exercise groups, those sort of things. And it's worth finding out from the hack coordinator what's on. Sometimes in a very small place you can improvise groups. A walking group would be an easy one to improvise for a number of people. You get 4 or 5 people together twice a week to go for a long walk. There are various kinds of, people get enthusiastic about various things like reminiscence therapy or music therapy or art therapy. I mean, they're not exactly evidence-based because the randomisation is hard to do, but the kind of things you have to say, well, why wouldn't you? If there's enough interest to do art therapy, why wouldn't you do that? Why do you wait for good evidence? I mean, it just seems like a sensible thing to enrich people's lives. And that is the type of thing, when we find a patient who is thought to be depressed and we think they're more demoralised and lonely, it's that type of thing that seems to make a difference. Also, moving them sometimes out of their own home. We like to keep people in their own home wherever possible, but sometimes if people are socially isolated and they're deteriorating, sometimes they resist going into residential care, and the family might say it will kill them, they'll just curl up and die. But in fact, often the reverse happens. The social stimulation available in residential care actually brings some people back to life again. So a lot of these problems occur as someone's brain is ageing. They haven't yet got to the point of having dementia, but they're no longer as sharp and active, and they're no longer as able to generate their own internal cognitive structure. It might be another 2 years before they get formally diagnosed as having dementia, but as it's emerging, they often lack initiative, and they will just sit and watch TV or sit and do nothing, and that's when their mood deteriorates. Because if you put someone in an environment with a bit of structure, and that might be in the home, getting someone coming around 2 or 3 times a week to take them off to an activity, or coming in to do the cleaning, or coming in to shower them or something like that. A bit of structure in their day will often overcome that paucity of mental activity and give them a little bit of a stimulus for the day. And then when you go to residential care, of course, it gets they're much more engaged.
We've been talking about things that might be considered the normal kind of mental problems that occur with age. But what about other mental illness in the elderly?
What we've been talking about so far is the 3 Ds, dementia, delirium and depression. By far the most prevalent problems, and they manifest themselves in all sorts of ways that can be diagnostically confusing and challenging to treat. But all the other psychiatric disorders also occur in the elderly, and some people grow old with their psychiatric disorder, such as schizophrenia, and sometimes they've never been diagnosed until they become old, and then physical health problems or some other death of a spouse or something unmasks the problem. So for an old age psychiatrist, we are quite often asked to see people who've had chronic disabling anxiety disorders, like obsessive compulsive disorder, all their life, and now that their partner is no longer there to kind of compensate for all the odd rituals that they do and the excessive hand washing, other people start to notice, and that kind of thing would be an example. Or chronic schizophrenia becomes an issue. The state government is supposed, in the health care agreement, the state government is supposed to manage mental health, and the Commonwealth government manages aged care, which creates a kind of barrier. But that works in our favour, or in favour of older people with psychiatric disorders. So someone with chronic schizophrenia who needs to live in a residential care setting will be confined to state-funded psychiatric hostels, which are of a poor quality. They're underfunded, where everyone's parent could end up in a residential aged care facility, and so there's a lot of political pressure to maintain the standards. They're much nicer environments. So when you have schizophrenia and you get to 65, you need to have a few other reasons, such as chronic arthritis or something like that, to get out of the state-funded system. You can suddenly access a much better quality of accommodation. So we're looking at those issues for our patients, trying to use various community resources, such as the HACC programs or the community aged care packages that are available from the Commonwealth funding to improve the lives of people with chronic mental disorders. The other big group of psychiatric disorders that's common at all ages is substance abuse disorders, alcoholism particularly. And we do see older people who maybe have been dependent on alcohol for a long time or have drunk too much through their lives, who, as they get older, as their social network deteriorates or as their brain deteriorates, start drinking more. As they become lonely and bored, they might drink more, and that may become a bigger problem.
Or the consequences of that drinking can be
exactly,
compounded.
yes, exactly. The cumulative effect of decades of drinking will suddenly, more gradually, become more and more of a problem, and dementia is one of those. So people who've drunk too much will usually present with short-term memory problems and executive dysfunction. So this is poor planning, judgment, impulse control, emotional regulation. Typically someone might be rather unmotivated. They might sit around a lot, but when they're frustrated, they become angry easily and quickly, and sometimes their lack of self-awareness means that they are socially embarrassing. They'll do things like walk around in the garden naked or make inappropriate comments, sexually explicit comments, etc., which can stigmatise them in the eyes of the community. Most of the people I'm talking about who've been drinking for a long time and are getting into trouble with their drinking have quite noticeable memory impairment, but they also have this executive dysfunction, and that's the combination of memory impairment plus the impairment of other higher cortical functions that means that you should call it dementia. I think often we're reluctant to label it as dementia. Once it's labelled as such, they're entitled to more resources and better quality care. And I think it's also a less blaming attribution. You can say, well, this person, yes, they are being sexually inappropriate, etc., but it's not their fault, they have dementia. I think that's a more helpful way of looking at it than taking a law and order approach, for instance.
Absolutely. But in terms of that kind of social disinhibition, any tips about how we might try and just start down the path of addressing some of that?
Sometimes a clear discussion with the patient and their relatives of the problem in a pragmatic, maybe not such a blaming, accusing way, but a practical, honest, straightforward way, saying, you have done the following things which upset other people, and you need to stop doing that, you need to start doing this instead. or people will become more upset and they may call the police, etc. You know, that kind of, and that may need to be repeated, and it may be that other people around the patient, such as their family, may need to be aware so they can repeat the information. That can sometimes help, but more often it's about distraction and engagement. So a lot of these behaviours that arise in this context is because of boredom and a lack of structure. People have a routine. If they get up in the morning for a purpose every day, even if it's going to a day centre or going shopping or something, it seems to occupy their mind so that there's less of that behaviour emerging. And that's the sort of approach we take. We try to engage them, supervise them, distract them, and give them realistic feedback repeatedly, so they can, what ability to regulate their own behaviour they have, they can still use. When it gets beyond that, residential care is sometimes needed. They're hard to sell to residential care providers, not the most appealing patients. But in residential care, you can do a more structured behavioural approach with the staff having clear guidelines for how to behave each time there's an incident and how to minimise the incidents. And that behavioural plan can be modified as time goes on. It's the sort of thing that the local psychogeriatric team can do in the city. In the country, we have some visiting psychogeriatric services that are able to give that kind of advice remotely. Clinical psychologist is often helpful in constructing those behavioural care plans. As a last resort, medication is sometimes used. It's not very effective, has side effects, but if we're going to do anything, if it's a highly aroused behaviour that's posing a risk, and I think it's the risk issues that might say that using rather unsatisfactory medications with some risk of side effects may be justifiable when there's a risk to staff in a residential care facility, or risk to the community, or risk to the patient. So what we generally say is a low dose of a high-potency antipsychotic. We used to use haloperidol. Now risperidone is probably more acceptable. It's approved for this indication in low doses, 0.5 milligram or 1 milligram a day only. There's not much point going further than that, and you'll start to cause falls, etc., if you overdo it. Haloperidol is just as good. It's not exactly more toxic than risperidone. It does accumulate though. So if you have someone on a low dose of haloperidol, as the weeks go by, it starts to seep into your fat stores and your bone compartment, and the brain receptor concentration will rise slowly. So it's probably better if you're going to have someone on long-term medication to use risperidone, which, as I said, is actually endorsed by the PBS for that indication. There are other things. We have the cholinesterase inhibitors that are available for treatment of Alzheimer's disease, and in a way vascular dementia, which can be described as Alzheimer's mixed, or dementia with Lewy bodies, which can be described as Alzheimer's Lewy body variant. It's only those medications taken on average are only modestly successful for cognitive improvement, and many people don't appear to benefit. We hope that they do benefit a little with time, that the rate of decline is slowed a bit. But with a patient who has behavioural disturbances, it's worth a try, I think, to use that approach. Because the behavioural problems may improve independent of any cognitive improvement. So taking that approach, and then there's also memantine. It's rather underutilised. It's marketed to improve people's cognition in the same way that cholinesterase inhibitors are. But it also has a kind of calming effect. So if someone is demented and they have an agitated type of picture where they can't sit still, they're always on the go, they appear to be distressed, you have to think of depression, you have to think of things like pain coming from teeth and various things that give them a really good going over from a medical point of view. But if it really does appear that this agitation and irritability is part of their dementia, then the memantine's worth a try. It seems to help some patients.
And thanks to all our guests for their time on this month's programme. We're back again on the 7th of August with a programme focusing on prevention. Don't forget that if you'd like to review this programme or any previous programme going back to 2008, they're all available on our website at ruralhealthwest.com.au. I'm Jerry Gannon. Thanks for joining us.